My name is Troy Watson, and I'm from Las Vegas, Nevada. I'm going to present a case today of a patient with a calcaneal fracture, non-union, with severe collapse and loss of calcaneal height. So this is a 50-year-old male that presented in my office, not initially, but subsequent to his calcaneal fracture. He had been treated, and he was a good year out from this injury. He complained of fairly severe pain in his hind foot, likely secondary to the subtalar joint arthritic changes. In this case, he was a smoker, which of course increases our postoperative risk of wound healing problems as well as non-union. And really, in this case, you have to consider what are your graft options. I felt that we needed to restore some of the calcaneal height, and also, in my experience, when you debride a lot of that fibrous tissue from these subtalar joint injuries, what we find is there's typically a gap, and that gap needs to be filled with something, either the patient's autograft or an allograft, and I've most commonly used allograft wedges that are about 1 centimeter in height. So in this case, I felt that I would need an allograft wedge, but I didn't want to just use the allograft alone. I wanted to increase the biologics in this case, and to do that, I used bone marrow aspirate concentrate, which would bring in some of the patient's progenitor cells as well as growth factors, which hopefully would aid in healing in this patient who is a smoker. So this is our final construct, and you can see in these images we obtained the bone marrow aspirate concentrate, and we're able to get about 5 or 6 cc's of concentrate. We then took our allograft on the back table, and after we contoured that graft, we soaked it in the bone marrow aspirate concentrate before inserting it into the prepared subtalar joint. And then we fixed this with the Arthrex 6.7 millimeter cannulated screws, and in this case we used 3 screws in total. For these cases, because of the patient's smoking history and the fact that this is a high-risk fusion case, I usually will non-weight bear these patients for 6 to 8 weeks at a bare minimum. Of course, we're checking radiographs and even, in this case, a CT scan postoperatively to make certain that that graft takes. And the outcome for this individual was successful healing of the subtalar joint with the graft in place, and the patient's pain was eradicated.